Good evening, everybody, and thank you for attending. My name's Helene. I'm from West Vic PHN, and I am working alongside my colleague Jade, who will be doing the behind-the-scenes IT. I'd like to begin by acknowledging the traditional owners of the land on which we meet today. I'd also like to pay my respects to elders past and present. So welcome, everybody, and thank you for attending. Just a little bit of housekeeping from West Vic PHN. Just to let you know that the majority of our webinar events are recorded and freely available on our PHN YouTube channel. We have a practice communique that we get sent out to practices fortnightly with lots of information, including external and internal calendars of events. So back to this evening, our meeting for today, the participants will all be put on mute. So if you have any questions, just type them in the question box and we'll have a designated question and answer session at the end. I'll answer these, I'll ask these on your behalf and it'll all be anonymous. Please make note of the West Vic PHN Health Pathway slide on the screen at the moment that's related to this topic. And our presenters for this evening are Celia Bolton, Physiotherapist, and Dr. Anne Hotchin, Obstetrician Gynaecologist. Thanks, Celia. I'll now hand over to you.
Thanks, Helene. Thanks, Jade. Thanks to West Vic Primary Healthcare Network for having me. And thanks, Anne, for all your support for this. I'd also like to acknowledge the traditional owners of the land, the Wadawurrung people of the Kulin Nation, from where I'm broadcasting tonight. And yeah, thanks for coming, everyone. I've got quite a few slides for you, but just to introduce myself, a physio from 1992, and I've got a couple of grad dips and certs, and I've recently become a meditation teacher, and my extra work is the CFA physio group, of which I've been a committee member for 5 years. I'm actually asking for help tonight and hoping to set up a bit more of a network around pessaries. And we're going to talk tonight about why the increased interest in pessaries in the last number of years. We're going to talk briefly about the Prolapse algorithm of management. I'm going to show you a good client handout that might be useful to give. We're going to talk about pessaries, obviously, the indications, the contraindications and cautions. And then we're going to get into the idea of pessary in primary healthcare. And we're going to talk about self-management, doctor management, successful fitting, where the GP role might fit with the physio, and we're going to talk about managing complications and removal. And at the end, I'm going to be asking if anyone's really interested in this area. I'd love to meet up and have some sort of special interest group. So why the increased interest in pessaries? Firstly, the impact of pelvic organ prolapse can be quite significant. And a study in 2020 by Toy, looking at the qualitative evidence of the experience of people living with pelvic organ prolapse, what they found was quite a lot of stigma, people feeling dirty, they fear gossip. There's a lot of stigma and shame associated with that. And there's concluded there's a vicious cycle of taboo, silence and misunderstanding about prolapse and its treatment. And this silence is exacerbated by a feeling that prolapse is not taken seriously in healthcare, which is an awful thing to hear. But that really fits with the tears that I see in the room, especially from younger women when we first start talking about this. The other part of this is the increased interest is the risk of having a recurrent prolapse after surgery. There's been some research come out that I'm going to ask Anne to interpret for us because that's her absolute expertise, but that is part of the thing that's driving the increased interest in pessaries. Anne?
Thanks very much, Celia, and thanks for organising this evening. I'm really pleased to be asked to be involved in this, as it's a little bit of an interest of mine, particularly as relates to self-managed pessary care. What the reviews of recurrence after surgery show us is that we really don't have for particularly anterior wall, anterior compartment prolapses, traditionally cystoceles, we don't have a really good lifelong surgical option. There have been various reviews done which are fairly heterogeneous, and this is a real problem with trying to get some idea about what the prolapse recurrence is after surgery, because often all of the different operations are lumped in together, and sometimes even they're lumped in with incontinence procedures such as slings. And so as a result, we've got these very broad ranges. As you can see from the systematic review that Celia's got up there, which looked at over 5,000 patients, 5,000 people who had surgery, they found that the recurrence rate on average was 36%, which is huge if you think about it. But that had a very broad range between sort of 8 to 50% roughly. And it, as I said, the samples in this group, so there were 25 studies, and if you drill down into the studies, you found that they were comparing anterior compartment, posterior compartment, apical prolapses, so vault prolapses, as well as I say, some of them even included slings. So we'll go to the next slide. So what just so you may be aware of what I've quoted and what I tend to quote people. I tend to say to women they've got about maybe a 20 to 30% risk of recurrence after a single prolapse surgery, and this I usually say for anterior compartment prolapses it's higher, it's up to the sort of 30% even, and for posterior compartments probably like closer to the 10 to 15%, with apical around about that 15%. That's what I've sort of come to, and it seems to have been the same from the beginning of my surgical training, which was back in the mid-90s, up until now. It hasn't really changed, but we will talk about the the blip we had when vaginal mesh was used, because that obviously, one of the big things with vaginal mesh, it was aimed at trying to reduce recurrence. So in the Whiteside paper here from 2004, so quite a while ago, these would be a lot of native tissue repairs. There were, a year after surgery, women were found to have 58% of them had recurrent prolapse, which went beyond stage 2, so just at the introitus, but only 10% had symptomatic prolapse. And that's something I always think it's important, is you may have an anatomical prolapse, but it may not be at all clinically significant. And I think that's really important, because often when we're examining women, if they've had prolapse, or if they just come in complaining, maybe some urinary symptoms, maybe some, dyspareunia or something like that, we'll examine and say, oh, you've got a prolapse. And in fact, that then raises the concern in the woman that she's got something that needs management. And so I think that that's one of the important things, is really, do you feel a lump? Is the question I would normally ask women when they tell me that they've been told they've had prolapse, because that to me is important. It's important in this whole assessment of recurrence. Is it clinically significant? But I think it's also important in the primary diagnosis with the primary prolapse. Thanks. Next slide. So if we look, this is a Cochrane review from relatively recently, and this was looking more at, I believe, the posterior compartment, and also whether or not vaginal versus sometimes the colorectal surgeons do prolapse repairs of the posterior compartment, approaching it from the sort of transrectally, or that way. But we found that certainly, rectoceles are best fixed through the vagina, and that would, I think, what most of the colorectal surgeons would probably agree with that too. The other surgeries you'll occasionally see that the surgeons do, like rectopexies and things like that, are more for rectal prolapse rather than, in fact, rectocele. Next one. Yes, so factors that influence recurrence. One of the factors which we'd hoped would influence recurrence, and I must admit seemed to have on my anecdotal evidence, though I must admit, if you see big trials together comparing native tissue repair, that's repair with the woman's own tissues, versus the grafts, which were, in most cases, the grafts they're comparing to a synthetic graft, so nylon mesh grafts, they seem to have a some reduction. As you can see, the biological grafts, which aren't the nylon meshes in this particular Cochrane review, they had about a 12% recurrence rate, whereas the native tissue 7 to 23%. This is anterior compartment, remember. This is the one that I think probably has the 20 to 30% recurrence rate in the native tissue. So we may be seeing an improvement with graft. And certainly, I would say I've seen anecdotally a reduction in recurrent prolapse in the women who've had vaginal mesh used for their anterior walls and for their posterior walls, but particularly for their anterior walls. It's odd for me when a woman comes along and has a mesh repair, it's odd for me to see a recurrent prolapse in that same compartment. What I often will see is mesh problems, you know, that because that's the reason they've come to see yourselves and then come to see me. But recurrence hasn't been a big issue. So I think while there's the research on this is not quite as conclusive, I would say I've seen a lot of I saw what I thought was an improvement in the risk of recurrence with use of the mesh, which obviously has its own other problems, which we can touch on in a moment. And the apical compartment, so these are your vault prolapses, and you can see that down the side we've got the sacral colpopexy. That's the one done laparoscopically or abdominally, where the vaginal vault is fixed with usually mesh. These days, they still use mesh for this, to the sacral promontory, and it's usually done with either a non-absorbable suture, or indeed has been previously done with small screws, small bone screws. That's pretty successful, as you can see. Small risk of recurrence. So that's pretty successful. That's the one you want to go to if you've got somebody who's got huge risks of that prolapse failing, i.e. someone with, you know, significant, major vault eversion, or indeed, significant obesity. So usually works, harder operation to do though, and so most of us general gynaecologists do the vaginal procedure, the sacrospinous fixation. That's fixing the vaginal vault with a non-absorbable suture to the sacrospinous ligament between the ischial spine and the sacral, the sacrum. So that, as you can see, has around sort of double the amount of recurrent prolapse. And that's often because the suture pulls out, because we don't tend to put the suture, it's a single point of failure. We put the stitch through submucosally through the vaginal vault, which means that it's not all the way through, because we've had concerns with those permanent sutures. If you put them all the way through the mucosa, you end up with chronic discharge. So while it works, it's not bad, but you can see that 1 in 6 women will, 1 in 7 women will come back with a recurrence of that prolapse. In requiring repeat surgery, you see it's significantly more on the whole than the more invasive sacral colpopexy. So sometimes that's a second line procedure if the vaginal procedure fails. From native tissue repairs, yeah, these are uterosacral ligament suspensions. So you're essentially suturing the vaginal vault to the uterosacral ligament, so not to anything particularly strong, as you can see. More risk that will be recurrent. Interestingly, not a higher repeat in this Cochrane review, not a higher repeat surgery, and I'm not quite sure why that would be the case, but it may well be that it's managed they're managed in other ways, or the feeling is that these surgeries, it may well be that women aren't suitable, but in this particular cohort, as I say, small studies, often quite heterogeneous. And we've crossed out the transvaginal mesh there at the bottom because we don't use it anymore. But that for apical compartments was one of the things that it seemed to hold out a lot of hope for. And as you can see, similar recurrent surgery rate, repeat surgery rates to the sacral colpopexy. So a pity that we haven't found a good graft yet, because that's no longer used transvaginally. It still is used through the abdomen. Okay, and so when you're seeing a woman who, when I'm seeing a woman who I'm trying to decide what to offer her, whether, what's suitable to offer her, one of the things that I'm always thinking about is is she going to come back with a recurrence? I'm a bit of a pessimist. I always, when I go and do some prolapse surgery, I always focus a little bit on, well, if she recurs, will she be suitable for a pessary? Because, you know, having taken vaginal tissue out, sometimes you can have caused narrowing, and so therefore you may not have enough capacity for a repeat, a good repeat surgery, which is one of the issues with the vaginal prolapse repairs, especially if you're doing front and back wall, you might narrow. And the other thing you can do is you can end up shortening the vagina with some of your surgery. So that's one of the things we're always mindful of as surgeons, is not ending up with a too shortened vagina, because then it's quite difficult to do a sacrospinous fixation at a later date. But these risk factors for the prolapse recurrence are young age. That's a very important one. If they've got a significant prolapse, that's the pre-op prolapse of stage 3 to 4, the larger prolapses beyond the introitus, beyond the vaginal introitus. If they've got levator avulsion, if they've pulled the levators, often the right hand side, but also left and right can be the case if they've had particularly forceps deliveries, are very much the risk for levator avulsion, though it can happen with spontaneous birth, and if they've had a family history of prolapse as well. But one of the things that has struck me, in sort of what got my interest in using pessaries was, I have to thank my retired colleague, Dr. John Viggers, because he was the one that got me interested in self-managed pessaries back in around about sort of 12, 15 years ago, in that he was being a sort of surgical perfectionist. He had realised over his years that native tissue repairs were not very good. They didn't hold, and as women's life expectancy increased. In 1990, when I graduated from medical school, it was 76, the Australian women's life expectancy. It's now 83, and so that's going to, and hopefully it's only going to increase. That women were often coming back for repeat surgery. So he was doing his previous colleagues' surgeries that they'd done for their patients in their late 50s, perhaps, or early 60s, and they were coming back in their sort of early 70s, still quite active, really wanting to live a full life, and having to have a prolapse repair. So he was very keen on only doing surgery once, doing it well, and which is one of the hopes for the mesh grafts. And the other thing that I'm seeing is a lot more women, from maybe a couple of generations ago, sort of from maybe my mum's generation, weren't really being too, particularly active in their older age. They, we're now having women in their sort of 60s who are looking after ailing parents and also grandchildren. So we do have, our pelvic floors have to last us a very long time, and so therefore using sort of that sense of doing things only when they're necessary. If we don't have a really good, lifelong treatment, a bit like with joint replacements, we should look at alternatives for prevention. Would be great, but I don't think, apart from cesarean section rate that can go up and up and up, we really don't have a lot of good prevention. So I think that's an important reason for looking at pessaries as an option. So thanks, Celia.
Thanks, Anne. That was fantastic. I learnt a bit there. The surgical complications from mesh, which is so unfortunate, and the Senate inquiry and the class action that's happened in recent years has made people a little bit scared of surgery, and so that's sort of driven the increased interest in pessaries. And so you would have been aware of that, and I don't feel we need to go any further into that. Another thing that's driving it is the work of a fantastic Uni of SA physiotherapist who's one of my colleagues and has taught me a lot. Her name is Trish Newman. What she has been doing, she's written with a colleague of hers, a gynaecologist, Chris Barry, and others, some pessary guidelines in 2012, and around that time they started trying to train up physios and nurses to fit pessaries. I went to 2 of those courses, And what she found is the take-up wasn't as great as she wanted, even though she provided all this fantastic education. We had models to work with, we had lots of feedback, and these guidelines that she'd written. And so what's happened now is that there's professional training at University of South Australia, which is a great thing to try and improve our ability to roll this out. Other thing that I think is driving it is the social media and the changes. Even after Me Too, there's been this flow-on effect of women having a sense of less stigma and shame and a little bit more empowering, so that they're actually looking for options actively, which is really interesting. Unfortunately, with social media though, there's quite a lot of low or moderate quality information on YouTube, Instagram and Pinterest. And that was found by PACE in around 2021. So the other thing that is happening though is you don't have to look very far on Facebook and you will see physios saying, oh, pessaries are such a great idea. This is a way to go. So you will see more people because of social media and being empowered. This is another factor that Trish Newman talks about, but we don't have a lot of evidence. I've got one bit of evidence to show you, but her anecdotal information, because she's been fitting since 2011, is that there have been women who are runners that wanting to keep active and use their pessary just for running, have actually over the years told her that they've weaned off their pessaries because they feel they don't use them anymore. But again, this is the only piece of evidence we've got, and it's only fresh and it's not great. They had 136 women between 4 and 48 months. 54% of them had a stage 3 prolapse, and they were given only self-care of a ring, so there wasn't any bespoke fitting of different pessaries for them. But what they found when they did a second examination, and that was 72 hours after removal of the pessary before coming back in and being reassessed with the same examiner who didn't know what the person's prior results were. They found the longer the use, the smaller the pop measurements became, and they found that there was a decrease in prolapse in at least one of the vaginal compartments, and they found reductions in all measures were observed. And this is a ring pessary only, but they did say that it might be a good therapeutic option with the reduction in measurements and absence of pop progression in the short term and improvement in quality of life. But if you look at it, 136 women started and only 50 finished. So we've got a long way before this appears at Cochrane. Yes. And what I am getting though is there are women who have seen on social media that they want to get, they've had a baby, they've got a mild prolapse they're aware of, and they want to get back into exercise, and they want to exercise hard, and that we want to encourage these women to do that for bone density and mood. But what we're getting is a woman said, I want a sports bra for my vagina, thinking of a pessary as a thing that could mean that she could exercise a bit stronger. No evidence yet. Other thing that is making people a little bit more interested in pessaries is that they can self-manage and remove. And I haven't personally ever fit a Portex, which is the vinyl pessary you can see there on the left. It's a more rigid pessary, similar sort of cost, but Seiko have this silicone, more flexible pessary, similar cost as well. And did you want to show?
Yes. Yeah, so these were the ones that I've learnt with. These are the Portex, and anyone who's fitted these will know that normally we fold them to insert them. And for these, if you've got any hand weakness, forget it. You will not be able to fold this. Even if you've got reasonable hand strength, it's quite hard to fit. And the smaller ones, they fly out of your hand like they're a flipping a bar of soap. So do never put gel on them when you're trying to fit them. Put the gel on the labia when you're trying to fit them and fit them through there. Don't put the gel on the actual pessary. But the other things what we used to do is we soak them in hot water. So it's quite difficult, quite a bit dangerous to be having this hot water. Then you have to sort of, once they get soft enough after about sort of 1 or 2 minutes in the hot water, then you just have to tip the water out, do it, and then just make sure it's not still too warm to insert it. Whereas these ones, I'll try and put that close. to the thing, you can see it's got two little indentations there, and that's where the natural, this is my non-dominant hand. I'm doing that quite easily with 2 fingers, whereas this one here with my dominant hand, there's no way in the world I'm going to do that without it being warmed up. So that's the Seiko pessary, and that's the one that I recommend. They are a little, as you can see, they're a little thinner, and so some patients who prefer these thicker ones, especially some of and find that, you know, being that little bit thicker, they do provide a bit more support. But this has made self-management really, you know, it's revolutionary. Though, having said that, my lovely mentor John Biggers, these were the ones his patients got, and apparently they coped.
Thanks, Anne. Okay. So I'm just going to introduce to you the Prolapse algorithm from the Australian Commission on Safety and Quality in Healthcare. I find this really quite useful. A bit of a big messy slide, but it's got algorithm of an initial assessment, so general health, symptom assessment, preferably with a validated pelvic floor questionnaire, bladder, bowel, vaginal and sexual function and bothersomeness, a physical examination, and pelvic organ prolapse quantification, which we also call the POPQ, which I'll talk about. This is where it's really important. We want to identify coexistent pelvic pathology, including cytological screening to cervix, and we want to determine if there's any epithelial mucosal ulceration is present, and then if they've got rectal symptoms, evaluate anal sphinctal tone and or presence of rectal prolapse if bowel symptoms are present. So the management, first line management is observation, so that means sometimes doing nothing, lifestyle changes, weight reduction, avoiding chronic strain and constipation, heavy lifting and chronic cough, and a correct position for voiding and defecation, which is what the continence nurses and physios do. Supervised pelvic floor muscle therapy with a continence nurse advisor or physio, and also pessaries with a regular review, and then local estrogen for women with hyperestrogenic symptoms or urethral prolapse. But you'll get the notes of this, and there is a link there to that if you're interested. So the POPQ and staging is actually quite a difficult thing to do, and I would say without a good speculum and that skill set, it's very hard to exactly stage, but we are going from 0 to 5, and there's measures in each of the front wall, back wall, the genital hiatus and the perineal body. We do like to take these measures and give someone a bit of an indication on where they're at. Underneath there, you can see that there's a POPQ tool. This is a really good thing to download if you want to show someone what you think is going on. It's a little app from the organisation, and you can push in stage 2 anterior wall, and you get a really good picture, and you can go normal you, and you can show what's happened. I found that really useful. And there's some pictures of anterior vaginal wall and posterior vaginal wall from Halen 2016. The ICS organisation do this great, every 3 years they do a book and the standards. And from that, they have this algorithm that I'll just show you. And they talk about the grades of recommendation. I'm pretty sure you're aware the level of evidence and grades of recommendation, A being better. So their algorithm is saying observation is C, lifestyle interventions, weight loss, treating constipation, avoiding straining at stool and heavy lifting, C. Pelvic floor muscle training reduces associated pelvic floor symptoms, grade A, may reduce the symptom of a vaginal bulge, C, may not reduce the extent of prolapse on examination based on the POPQ, B. And here we go, vaginal pessaries, when successfully fitted, may reduce prolapse symptoms, B, need to be regularly reviewed, C, high rates of discontinuation, C, and then the local estrogen, grade B. So there's our management. I just want to show you this handout. The links are there. So this is from the Australian Commission on Safety and Quality in Healthcare. It's beautifully worded. There's a lot of people put a lot of work into this, and it just says these are your options, and then goes into what they are in some detail. It's just fantastic. So now I wanted to talk to you about the primary care role here. There's a new guideline that I have referred to help set up the pessary clinic that I've now set up with at Avonlea on a Wednesday, and using all the available evidence I can. And obviously it's fantastic to have Anne nearby, and I've been picking her brains very strongly. But we're going to talk about what are the indications for a pessary. It's short or long-term management of bothersome symptoms of prolapse if she has a preference for or is willing, and if there are no contraindications, and agrees to regular attendance for follow-up. It can be used as an interim solution for those who have not completed their family. If they want to explore the idea of surgery, surgery will be delayed until that time she's finished. It can be used to assess the effect of reducing a prolapse on bladder and bowel function prior to considering surgical management. And it can be a tool to delay surgery until a woman has less lifestyle pelvic floor load. That's what Anne was just talking about. Let's wait until that person do one good surgery when we know that it's her lifestyle is going to prevent some of the recurrence. And then what we're bringing in now is that idea of self-management. Daily use, perhaps, with removal 2 nights a week for rings or a cube. I'll show you what that is, nightly. Or intermittent use for those wishing to return to vigorous exercise, or work, or cope with prolonged standing, say, for instance, with an unsettled baby. Contraindications would be definitely poor compliance, obviously active infection, inflammation, unexplained bleeding, or ongoing vaginal or cervical cancer, and previous radiotherapy affecting the vaginal tissues, severely atrophic vaginal tissues that has not responded to pre-pessary estrogen treatment, the vaginal space is too narrow or too short to fit a pessary, and identifiable synthetic mesh erosion. And the caution required is poor vaginal health, where estrogen has not responded, and a synthetic mesh has been placed in the vagina during previous surgery and or pre-existing vaginal pain, pudendal neuralgia. So self-management, this is what the UK guidelines is saying. It's recommended that any woman who has been assessed and found suitable and has agreed to try a vaginal pessary should be offered the possibility of self-management if this option is supported and available. This puts the woman in control of managing her own condition to suit her lifestyle. To self-manage successfully, the woman needs to be confident about inserting, removing and cleaning the pessary, and be able to order a new one, book and attend follow-up appointments, and ask for advice as needed. All the elements of successful self-management can be taught by the pessary practitioner with verbal information given together with written guidance, including contact details in case an earlier appointment is needed. So what am I doing? Well, I'm starting with low risk and leaving the higher risk to where it belongs, and where there's more knowledge and better better speculum visualization. But I am fitting 5 types. So we've got the basic ring, which is bottom corner here, and then the ring with support. And then these 2 here is the ring with support and the knob. The knob is used for if someone has stress incontinence. And there we have lastly the cube, is also what I'm fitting. The Coliform is something you may have seen, but that's mainly for exercise and for stress incontinence, but we don't necessarily call that a pessary. So what does it look like? What we need is a pre-pessary examination by a GP. And the first fitting, there's education, there's an agreement met, there's an examination, there's measurement, there's a fit, and then we test. We get I get the woman up, and does the same. The pessary's in place. We get them to jump and cough and squat, and these younger women are doing star jumps. I might even get them to run out to their car, come back, and then to see if it's moved, if it's fitting, and if it's still comfortable. And then we do a test void and then removal. They come back at 1 to 2 weeks to see if they've got any ongoing symptoms. I'm hoping that they would get at least a 70% improvement of symptoms to make it worthwhile. And that's generally what women say, because there's a bit of bother with it, that if their symptoms are 70% gone, then they're probably going to be using it on an ongoing manner. Sometimes we need to refit because they fall out. I've got to check that they can remove them and put them back in. At 4 months, we're repeating it again. What I'm starting to do now with these women is that some of them need a smaller size because things are improving, and this is a postnatal woman. And at that point, I'm getting them to self-assess what is happening with their own prolapse, because I want them to wean off these pessaries over time. So I want them to try with and without, and to know where their symptoms are. And annual follow-up is as above. We're going to replace the pessary, and at that point there should be an examination, which I'll describe. We could actually, instead of self-managed, have doctor-managed, and that's obviously gynaes and GPs could be doing that. I'm sure some of you are. And that's if a woman's not suitable for self-management. And then often the review is a little bit shorter, and the advised patient to contact if there's bleeding or heavy discharge. Anything to say there, Anne?
That's absolutely fine. I mean, I see, I have to defer to you, Celia. I see very few women who are very in the sort of postnatal age group. It's not yet become a sort of a routine thing. So I'm mostly seeing the women who are often post-menopause, definitely post, childbearing, but quite a few years, and many post-menopausal whose, symptoms have just been, maybe it's they've managed them like they have, they've done the observation and what have you. So often seeing those. And so for those women, weaning off the pessary is not obviously something that we're looking at, because they're steady state, and often it's going to get worse until their activity level means they're not sort of providing pressure on their pelvic floor in the case of ones where it hasn't gone beyond the introitus. So yeah, I definitely offer all of the women for whom pessary is thought to be an alternative to surgery, offer them self-management, but not all of them will manage. I reckon about 80%. And the issues about how, the issues I'm seeing in the postmenopausal population are to do with psychological issues, to do with comfort with inserting and removing something in their vagina. Dexterity, so actually being able to, I think, as I say, these softer pessaries, they're fine for someone of, my dexterity, but sometimes they are really not. The women with arthritis, will find that that's quite difficult, or, arthritis in their hands or arthritis in their shoulders, being able to actually get it in and get it out. So they're probably the two big things that make self-management not suitable. And so for those women, the more traditional thing that those people of my generation, doctors of my generation, were taught was pessaries were for women who are not suitable for surgery, and they are put in by the doctor, and they are seen every 6 months to have them cleaned, removed, cleaned, replaced, and the any issues managed with their vaginal mucosa.
Thanks. So a woman will come hopefully to UGPs before they have a pessary fitted, and what's been recommended is an abdominal flank examination for masses and bladder distension, a bimanual pelvic examination for a pelvic mass, and if those two aren't possible, alternatively a pelvic ultrasound could be done. And if somebody has recently had a pelvic ultrasound or a laparoscopy, we don't necessarily need to do that examination. Anything to say there, Anne?
No, that's correct. I think it's really just making sure that this sort of maybe a recent a development of symptoms isn't due to some internal abdominal issue causing the prolapse to come down, such as ascites, an ovarian cyst. It's interesting, sometimes women who've previously had fibroids, as their fibroids shrink postmenopausally, will find that their uterus getting smaller will be the issue. That's what will cause it to come down, and it's being held up by the fibroids.
Oh, wow. Thank you. And so what does a successful fitting look like? Well, we're trying to put the biggest pessary in that's comfortably retained during upright provocative activities such as walking, squatting, valsalva and coughing. The pessary is not felt by the woman and does not cause pain or discomfort, and it doesn't obstruct bladder or bowel emptying, and hopefully it doesn't provoke occult urinary stress incontinence. So that's something we check as soon as that pessary goes in. If they're coughing and moving about, do they have some incontinence? And that's come from the 2012 guidelines. And I've got what we call a sterilisable fitting set, which does make it a little bit easier to do. And at the annual examination, what we need is a vaginal speculum examination for mucosal ulceration. Coming from me, there'll be quite a lot of communication regarding if you've done the examination. There'll be a letter to say when the pessary has been fitted and what terms of use she's decided to, and we have decided to use. And there'll be an annual assessment. And when I've seen her annually, you'll get a letter. And if the person's lost to follow up, there'll be a letter as well. And then Inner Strength will be handling the reminders that you need to go to your GP to get your examination at that 1 year. So complications during usage, I'll leave it with you, Anne.
Thanks for that. Focusing a little bit on obviously different cohorts. What I would say is that self-managed pessary with regular removal and replacement, so overnight removal and replacement sort of once or twice a week minimum, very much these sort of complications are very uncommon. It's the foreign body reactions that having a foreign body in the woman's vagina that cause the majority of pessary problems for sort of long-term usage. So abnormal bleeding. So I usually, if a woman's removing and replacing the pessary, I ask, when that's occurring. Is it occurring during removal and replacement only, or has she got bleeding? Does she have bleeding that's happening while the pessary is in situ? Often, because the postmenopausal women I'm dealing with often are on either antiplatelet antibodies or maybe even anticoagulants, so sometimes they are more prone to bleeding just from minor trauma. And if they're postmenopausal, as a lot of my ladies are, how well is the vagina estrogenized? And so that's a very important thing too. And so if they're removing and replacing, they might also complain of soreness and discomfort with removing and replacing. But if not, then obviously if it's staying in, I have a good look to see, does the vagina look well estrogenized, and is she using any supplemental estrogen? So with my examination, I have a look to see if there's anything external, because there might be an external reason why she's bleeding. On speculum, that often we find atrophy or some inflammation with an infection, so abnormal microbiology. Abrasions, very common with long-term pessary use, and we often have to manage these as below. If she still has a uterus in situ, so if she's not had a hysterectomy, then I do a co-test, as you would for any other abnormal postmenopausal bleeding, because you can't assume it's just from the pessary. And I also do a micro swab high vaginal and an affirm swab through clinical labs looking for bacterial vaginosis. If she's still got a uterus, also she ultrasound her endometrial thickness to look for any uterine causes of bleeding. Obviously manage depending what the cause is. If it's an abrasion, and if it's a very minor abrasion and I find it and she's not having bleeding, I'll often leave the pessary in and just replace her estrogen for a couple of months, so either cream or vaginal pessaries. With larger or deep abrasions, I do recommend leaving the pessary out for a couple of weeks, re-estrogenizing, and then getting her back to have it replaced, which most women will tolerate. Some not, some will really struggle with that, but vast majority will tolerate that. Obviously the swabs, if the swabs come back, treat whatever's on them. One of the things that sometimes comes back on your report is coliforms, and often the pathology labs will comment that this is often a reflection of low estrogen. So if you see coliforms and the woman is not on estrogen, is postmenopausal, if they haven't made that comment, it is reasonable to, if you can, replace their estrogen for a few months. Yes, we said that about removing it. And the other complications during usage, which is difficult. This is one thing I haven't come across, but difficulty removing. So if the woman's unable to remove and it's causing her problems, and I suppose the main problem it would cause, apart from pain, would be difficulty with emptying bowels, or very, very, very rarely in the kind of, you know, if you've been using it for a while, it'd be very strange for her to have retention, urinary retention. But bowel difficulty can be an issue with pessaries longer term.
Thanks, Anne. So this is very unlikely to happen, but I thought I would include it. So if a woman does present to you with a bit distressed because she can't remove her pessary, I think we already know that it only needs to come out two or three times a week, and also that they could call me instead. But I just thought you may be interested, if you were to be in this situation, to be a little bit prepared. And so I love what Anne said, is that if you see this situation, it's a great idea to go, is this an opportunity to teach her again, to support her in her desire to self-manage? And so this is what we would do, is we would reassure, we would try different positions, we'd get them to squat, they maybe stand with one leg on a chair, and then they could do the Valsalva manoeuvre to move it just a little. But Anne, would you like to talk about if they need to remove it?
Yes, so if you've got a situation, and this is, it's happened to me a couple of times, more women who come and said, you know, look, I've tried, Anne, I've tried as hard as I can, and I cannot get it out, and they're really keen to do the removal and replacement. That's often because they've got a relatively high prolapse, like a high cystocele with still got good pelvic levator ani muscle support, and so the pessary is sitting up quite high in their vagina, and so to actually for them to get around to remove it is quite difficult. So if all of those things that that Celia's mentioned haven't worked, if we've tried to sort of say, okay, we'll see how you go in the office with me, then usually I get them to, a bit like what you do with the retroverted uterus, to try and find the cervix with speculum, get them to lay on your examining couch with something under their fists, or a pillow or something like that under their buttocks, to lift their pelvis up a bit. And then you should be able to put your gloved finger in and locate the leading edge of the pessary, slip your finger through the aperture. If it's a ring pessary, which say, you know, 9 out of 10 times they will be, and remove it, extract it. If it's a cube pessary, it's got a little like a thread type thing that you can slip your finger through. And if you're lucky enough to have a lithotomy, like a gynae couch where you can put them into dorsal lithotomy position, that's also helpful too, because then you can again examine, you know, pop your finger in and find it. If you're really struggling, put the speculum in and you should be able to locate it. And then if you for some reason can't reach it, I've never had this happen with a ring pessary where I can't do the removal. You can reach in with a pair of sponge holders and grasp it and pull it down to the point where then you can get your finger through. But I've never had that happen, to be honest.
Thanks, Anne. So just to finish off, I'm going to show you the way in which they're sitting. So often that's where the ring pessary will sit. And to remove, Anne's covered that. We've talked about the flexibility of it. What you want to do is to rotate the ring so that the notches are sitting vertically, and then hook it in gloved index finger, just like she said, and bring it down to the introitus. And at that point, try to squeeze it like so as you're removing, to ease gently out of the vagina. And this is the same with each of these. The support pessary, the notch is the larger hole, so you would rotate it with a finger so that that larger hole is sitting vertically, and then you can do exactly what you did with the ring. Get it down with the finger through that hole, down to the introitus, and then squeeze and ease gently out. If you come across one with a knob, the knob usually sits anteriorly, but the notch is such that it's that same as the support one. So you want to rotate that so that it's sitting laterally instead of anteriorly. So then you can squeeze it and bring it down the same. And the contiform is really very unlikely to be something you'd need to remove, but that's also a very flexible thing. A finger would go in to that anterior wall and draw down slowly. I just wanted to show you the position, or how the cube, and how it's very flexible. And you can see that there is a little tag you can hold. But removing the ring pessary, because it's a smaller one usually than the ring. When a woman is fitted one ring size, we would usually go one down with the cube. The cube's usually used for women whose pelvic floor is really not very good, and it actually sticks there with a bit of suction. So you've really got to break the suction. So use an index finger around the edge of the cube, and then use the index finger to find the loop and bring that loop downwards. It can rotate, and then with a really gentle zigzag movement to keep the suction open, bring it down to the introitus, and then try and compress it. As you can see, good fingers are needed, and to ease it gently out of the vagina. So that concludes my talk for this evening, and I'll just over to Anne if there's anything you would like to say, Anne. But there's my contact details. What you can see there in the lower link is I've made a little web form to request that anyone that would like to be someone that gets involved with pessaries. I'd just love to have more contact with people that are on a learning curve with me and work together. So if you're interested, I'd just love you to fill that in. The referral for Prolapse is just the same at Inner Strength Healthcare, but the pessary clinic is just Wednesday mornings at the moment at Avonlea Clinic with Anne at Yarra Street, using my usual number, but my mobile phone number's there. I'd just love to hear from anybody. Anne, would you like to say anything as we finish?
No, but thanks, Celia. I've really enjoyed getting this, being involved in this talk with you. I've learnt a heap. My pessary, I suppose, journey is pretty much self-taught, because, as I say, we learnt to use, two pessaries when I was training, which was the ring pessary and the Gellhorn pessary, shelf pessary as it was called. We still use those, but since I've been with Celia, I've certainly started using the cube pessary just in the last few weeks, and my very first patient that I used a cube pessary with, Celia gave me some degree of courage to say, this is something that I should be able to use, because very often I looked at pessaries in books and online as ones that weren't available in Australia and hadn't been available in Australia easily, and so therefore stuck with what I was used to. So your sort of desire to improve in this situation is very inspiring. So thank you very much, Celia.
Thanks, Anne. I have to say that I came to this a little bit reluctantly, simply because it's a new area for physio, and I just really like that support, and I just want to extend that. Happy to support anyone that's interested, and really would encourage anyone who wants to get involved. So thank you for having me.
Hi everyone, it's Helene here. Pop your questions in the question box if you have any. We've got 5 minutes to go. I do have one question. Recommendations, guidelines for qualifications for physios, continence nurses to complete to ensure that they're fitting pessaries correctly, standardised training.
Yeah, that's the Uni of SA one. That's the only one available that I'm aware of in Australia. And yeah, that's the one we'll all be going to do. Any other questions?
With intercourse with pessary.
Yep. Yes, interesting. Look, it's an interesting point. I completely neglected to mention that that's one of the big reasons that self-management is something I encourage for women. And women, I know of women who do have intercourse with the vaginal intercourse with the ring pessary. I know of a woman who was sexually active, though I didn't go into detail as to whether or not she was having penetrative intercourse with the Gellhorn pessary. So, but she and her partner were happy with their sexual life. So, you know, she's certainly fine. Yeah, you can definitely have intercourse with the ring pessary in. It, however, is probably a disincentive to do so, and I think that's why often that's one of the things I'm trying to work out when I'm discussing with a woman what she wants to do with pessary management, how important sexual activity is to her, to how you know, much the pessary option will suit her. Because if for a woman it's extremely important to have penetrative vaginal intercourse, then and she isn't suitable for a ring pessary, then sometimes that's a woman that I am actually suggesting surgery is a better option. Certainly, my usual recommendation for women with self-management, for a couple of reasons, is remove for intercourse, remove overnight and put back in the morning after opening your bowels, if you can, you know, arrange that, because pessaries falling out, which is something we didn't discuss. Pessaries falling out at the wrong time, so difficulty getting that's one thing, but falling out at the wrong time is also another anxiety, and can happen that for women. And so certainly the commonest time that they tend to fall out is during opening the bowels. So replace it, if they're removing and replacing, replace it after emptying the bowels.
Yeah, the other thing that I'll say is also that if they prefer to have it already in, is just to place their hand with some toilet paper, just support during a bowel movement.
Okay, I've got another question here. What sort of wait times for pessary clinic with the physio? Are there many GPs also fitting at the moment in the Geelong region?
So the wait time is, if someone's referred, they need to be seen from the point of view of just pelvic floor exercises, lifestyle, and assessment. And then as soon as we think they're suitable, it's just as quickly as they can get to their GP and straight in. It's not a fully booked service at the moment. So not much wait time.
Where are the pessaries obtainable or bought from?
The place we buy it from is Profem, P-R-O-F-E-M, Profem. They also go under the name of Sayco, S-A-Y-C-O, and that is the silicone one, and that's where those fitting sets are from as well, which is very useful because often you need to try a few in one setting just to find what feels comfortable. Sometimes, like, you know, trying on different pairs of shoes to find something that's just right. So the autoclavable part of the fitting set's fantastic, that you're not feeling limited to having to throw out all these pessaries. It's been great.
Another question, what age can you start using pessaries? Contraindications, personnel, for psychological, cultural refuge, post-sexual violence issues?
Yeah, and that Anne's referred to that, haven't you, Anne, about the psychological impact, and you very quickly know, don't you? You start talking and you can see it. So that,
yeah, very much, and yeah.
I was just going to say age. It's actually I wouldn't say that's much of an issue. It's about maturity and comfort.
And
yeah,
how are they?
And definitely the you know, there's some things which will restrict the use of pessaries. I think the thing we occasionally see is the postmenopausal woman who's nulliparous, who has a prolapse, and often her vagina is not, it's too narrow. She's got basically a kind of uterine prolapse, and so that sometimes can be an issue.
And how are they cleaned? So the fitting ones are cleaned autoclaved, and the ones that the women take home, they're rinsed in water and then washed with warm soapy water, and then rinsed any sort of cleaning product off and dried and ready to go.
Yep. And if they fall in the toilet, our fall in the toilet, we just get them to put a plastic bag on their hand, reach inside, get it out, and give it a good clean with good soap and water and wash till clear. So they're usually pretty good, and they last. The remove and replacement ones will last. I've had women that have been using them for. I just saw a woman yesterday who used hers for about 3 years, and it was just beginning to become a little bit stained. And so, they cost $30 or $40. Women can, ring up, and if I'm moving replacements, they just ring up and we just order them one. But really, you could just order them online if you wanted. I don't think Seiko only provide to medical practices. I'm not sure.
Oh, so I think you've just answered the next question. What sort of cost is for the pet? Is it for the cost of the pessaries, and do you need to replace the pessary with a new one after some time, even if no change in size and not planning to wean pessary?
Yeah, so really you can look at the pessary and tell if it's damaged. If it starts getting really stained is when I would change it. So a little bit of so it sort of yellows off a bit after it's been in for too long, and that's usually the ones that have been sitting and replacing. So probably one of the ones that I'm replacing where the woman just leaves it in all the time and sees me every 6 to 9 months, I probably replace it every 2 years, I reckon. And as I say, I got the last one I saw 3 years out of her.
Okay, thank you. That is the end of the questions. I'd just like to take this opportunity to thank you both so much. What an interesting topic it was tonight, and really, really interesting. We got lots of feedback. Thank you for everybody for attending, and don't forget to fill out your evaluation. If there's any other topics you would like, pop them in there and we'll see what we could do. Just another comment, Celia, I will contact you about that in an email. Somebody said they'll be in touch. She works in Warrnambool, so about the course, so she'll be in touch with that. And now there was another comment here. Thanks so much for the talk. Very helpful for GP, and feel I could provide increased service for women. So there you go. So thanks everybody. Have a good evening. See you at the next one.
Bye. Thank you.
Thank you. Bye-bye.